those all together, you'll be fine and you'll get it correct. Okay, so with this, what I want you to take away from is that pretty much when they are initially diagnosed, they may not have any symptoms. Not to say that it's in a latent or dormant state, there are just no symptoms that kind of arrive. As they start getting sick or taking antiviral medications, that's what we're wanting to make sure that they can actually build up their immune system so that they're feeling well, which is why we see in a lot of HIV patients that they're not really progressing on to AIDS because the antiviral medications are keeping the disease stagnant. It's not curing them at this point, but it's keeping it stagnant. Now, what's going on now with the whole AIDS, cure, that's something completely different. But for right now, we have had the medications and the drugs to actually prevent it from progressing into full-blown AIDS by taking the antivirals. All right, we already talked about the CD4. I'm trying to think what else. Okay, and then we know the late stages of it is pretty much when they have full-blown AIDS. Know the symptoms of it, which you guys are kind of aware, and then know of Kaposi sarcoma, which is one huge sign that we know that when they're having full-blown AIDS at that point. All right, this is the box I was referring you to. And so these are the tests that you're going to do. So the most accurate test is going to be the Western blot test, which is going to detect the antibodies in there. So anytime that we're able to see, and we can take it back to immunity, we're looking at the antibodies or what's actually being fought, which ones are present, will let us know which stage or where they're at in their disease prognosis. So that's the main thing. The rapid test is great. It's like 99% accurate. I think this is rapid, yeah. It's 99% accurate. It can give you, if you're negative with that, you do not need to be tested again. If you're positive, you do need to go back and get the Western blot test to make sure that you have a positive and not a false positive. All right, and so I'm just gonna let you guys kind of go through, we already kind of talked about certain things with AIDS. These are just other, when we were going through candidiasis and herpes simplex and herpes zoster, we discussed how these symptoms can arrive in AIDS or in AIDS patients. So pretty much knowing that since they are immune suppressed, that they're more prone to any of these manifestations. Okay, I'm good. I have to look and see where I'm at.
Was that just his skin?
Uh-huh.
Like,
Got
from
right there.
AIDS, or he just has crappy skin?
That's
No,
shingles.
so it's the herpes zoster, which is the shingles outbreak that has it all on. That's affecting which nerve? It's all coming back to you now. You don't want it to come back to you, but it is. You're gonna make it. All right, so we already kind of talked about hairy plakia, knowing it's caused by the Epstein-Barr. And pretty much, we all know this is associated with AIDS and HIV. Okay, so with this, I need you to know that it's the herpes virus type 8. So that I do need for you to take away from it. And that affects 20% of AIDS patients. The appearance of it is going to be asymptomatic, enlarges with red papule or plaques, and then late you're going to have these lobulated, like purplish kind of vesicles all around. All right, so knowing where it's going to be at, so in your book, it doesn't talk about buccal mucosa, but you do need to know in the order of appearance. It's going to have start on the heart palate and then go to the gingiva. And remember, this is going to be on keratinized tissue as well. It can be treated with chemo or radiation, and it will disappear and become smaller with chemo or radiation, or once their immune system actually starts to strengthen. So that's that picture.
Ooh.
Okay, so, and I'm just going to kind of go through this a little bit quickly. So linear gingival erythema, where that is, if you're looking at it, what do you think is located? what do you think you're gonna see? You're gonna see
right
what?
at the marginal.
Right at the gingival margin, you're gonna see that red line kind of scalloping the gingival margin. So all that is just kind of telling you that that's where it's starting at. We're gonna know it's bright red, and the gingiva is gonna be very sensitive, spontaneously bleed, and it can be sore. You can treat it with chlorhexidine. I think this is the one you can, yeah. Treat it with chlorhexidine, but there's no telltale sign that that's actually gonna happen or help. And what you're looking for is that we're seeing this right here. What's missing from that can let us know that it could be generalized inflammation? Swelling, but what else? What do we see on here that's actually missing? Calculus or plaque. Plaque, we see a copious amounts of plaque, we're gonna notice that red gingiva, inflamed gingiva there. But see here, it's not, you have a little bit right there, but on the teeth, we're not seeing that thick kind of plaque that's surrounding that can let us know, okay, well, what's actually causing this? So that will let us know through clinical diagnosis that this is not just pretty much plaque-induced gingivitis. All right, so we know about NUG. Tell me about NUG. What did we learn from last week? Were we here last week? No, week before last. What happened?
It's where like an overgrowth. Is that the overgrowth of the tissue, and it starts to.
So, right, so remember we talked about the punch out papilla. We talked about how overgrown it is. So I don't want you to think about it as having like, a patient taking Dilatin for seizures, that kind of overgrowth. But it is, due to the bacteria, and it has that foul odor towards it. It bleeds very easily, whereas somebody who is using Dilatin or so for seizures, it may not bleed.
Be more hard.
Right, it's a lot harder, more pallor, not really keratinized. So here, pretty much, we would go ahead and do our same periodontal treatment with it, or therapy with it, and make sure that we can kind of get it under control, but sometimes it's not receptive to it. And then we have the same thing as NUP. So NUP is pretty much going to be the same type of manifestations we're going to see in NUG. It's going to be affecting the bone, because now we're talking about the periodontal of it. So we're going to see that's going to start in the anterior teeth and progress to the posterior teeth, and we're going to see a lot of bone loss, which I have a good picture of. So these symptoms are pretty much the same thing as NUG. It's just we start going more into bone destruction with our NUG. And that's what we need to look at. You think we're going to have some mobility?
Yeah. Oh yeah.
Just a little. All right, so these are just some other things that you guys can look into. Thrombocytopenia purpura, what is that? If you had to think about it, if you had to break this word up. So what it is going to be a decrease pretty much in the amount of red blood cells that we're having. So with that, we're not going to see as much, the platelets aren't going to be there, so which means we're going to have more bleeding going on. So that's what's going to have that exacerbated effect with the gingiva. And then I think that's it.
And that's how you get through 131 slides.
I know.
And still have 20 minutes.
And still have 20 minutes to do. All right, get in your little teams. Let's knock this out.